Okay. So guys, yeah, we are resuming to the next part of the upper limb. Okay. Since we were discussing about the radial nerve, what are the groups of muscles the radial nerve was supplying? The radial nerve was supplying the extensor groups. Okay, it is supplying the extensors of the elbow and the extensors of the forearm. So we'll just add few points related to the extensors of the forearm, and then we'll go to the next now. Okay, see, if you see the extensor muscles, okay, so there were 12 muscles. We told about those 12 muscles, and we classified them into superficial and deep group. And here is the deep group muscles which are shown here. See, more important is when you see these muscles, okay, they have got specific actions. Okay, when these muscles goes to the fingers, okay, so they cause different actions. See, for example, if it is an abductor pollicis longus, what you see here, okay, you see a muscle here, this is called as abductor pollicis longus. This abductor pollicis longus causes abduction of your thumb. Okay, this causes abduction of your thumb. Supinator forceps, okay, it causes supination of the forearm, it causes supination of the forearm. So each of these muscle has got specific functions. See, there is an important muscle in the extensor group, okay, which is called as the extensor digitorum muscle, which is called as the extensor digitorum muscle. Okay, so it causes extension of the metacarpophalangeal joint. Okay, it causes extension of the metacarpophalangeal joint, and when this extensor digitorum muscle crosses the metacarpophalangeal joint, it splits into 3 bands. Okay, it splits into 3 bands. Okay, so what you see here is the central band. Okay, is the central band, and what you see on the distal part is the lateral bands of the extensor digitorum tendon. Okay, this is the lateral band. Okay, when the extensor digitorum forms band, it also gives rise to fibrous expansion on the sides. Okay, so this fibrous expansion on the side is called as dorsal digital expansion. Is called as dorsal digital expansion. It is called as dorsal digital expansion. Okay, so guys, please be clear. The extensor digitorum muscle, when it crosses the metacarpophalangeal joint, okay, so what is this? So this knuckles, what you see here, this area is the area where you get the metacarpophalangeal joint. So the tendon, that is extensor digitorum tendon, when it crosses the metacarpophalangeal joint, it expands to form an expansion called as dorsal digital expansion. And in this dorsal digital expansion, you see the extensor digitorum tendon splitting into 3 bands. One is the central band and 2 lateral bands. Central band is getting inserted into the middle phalanx. Okay, it is inserted into the base of the middle phalanx, and whereas the lateral band, they fuse and they get inserted into the okay, and they get inserted into the base of the, okay, and they get inserted into the base of the distal phalanx. Okay, distal phalanx base. Okay guys, clear? So dorsal digital expansion, if you see, it is a fibrous expansion over the dorsum of the fingers. What is the importance of this dorsal digital expansion? This dorsal digital expansion receives insertion of the 2 important intrinsic muscle of the hand. One is the lumbricals and another one is the interosseous. Okay, another one is the dorsal and the palmar interosseous muscles. Okay, so this interosseous muscle and the lumbricals are the important intrinsic muscles of the hand, and they get inserted into the dorsal digital expansion. And if you see this interosseous muscle, they get inserted proximally to the fibrous digital expansion. Okay, so this interosseous muscles, maybe the palmar interosseous or the dorsal interosseous, they get inserted into the proximal part of the dorsal digital expansion. So since they get proximal insertion, they are called as the proximal wing tendons. They are called as proximal wing tendons. So if somebody asks you what is called as an proximal wing tendons, one is called as an proximal wing tendons. So these are the tendons which is getting inserted, or which are getting inserted into the, okay, which are getting inserted into the dorsal distal expansion. And what are these proximal wing tendons? They are the palmar interosseous. They are the palmar interosseous muscles and the dorsal interosseous muscles and the dorsal interosseous muscles. Okay, and the dorsal interosseous muscles, what are called as distal wing tendons. These distal wing tendons, okay, so the lumbricals which is getting inserted more distally are called as the distal wing tendons. And what is their function? Through this dorsal distal expansion, these muscles causes extension of the interphalangeal joints. These muscle causes extension of the interphalangeal joints. Okay, so if you want to extend your interphalangeal joint, if you want to keep your hand like this, if you want to extend your interphalangeal joints, okay, this extension of the interphalangeal joints, is produced by this wing tendons, is produced by the wing tendons. And how many wing tendons are there? One is called as proximal wing tendon, another one is called as distal wing tendon. So please remember guys, the dorsal distal expansion is found by the extensor digitorum, and to the extensor digitorum proximally certain muscles are getting attached, they are called as proximal wing tendons. Distally a muscle is attached, that is called as a distal wing tendon. The muscle which is attached distally is lumbricals, and the muscle which are attached dorsally are the interosseous muscles, okay. So this is about the dorsal distal expansion. Now what happens if there is an injury to this bands, or if there is an injury to that dorsal distal expansion? See, if you see here, you can see the lateral band here. If the lateral band gets injured or when it is cut off, what happens to the distal phalanx? Okay, the distal phalanx goes in for a flexion attitude, it cannot extend. Okay, so this extension of the distal phalanx is produced by the lateral band. So when the lateral band is injured, the distal phalanx goes in for a flexion attitude, and this kind of finger is called as a mallet finger. So this is called as what? Mallet finger. What you see here is a mallet finger. So where you get distal interphalangeal joint flexion, there is loss of DIP extension, there is loss of DIP extension, and this loss of DIP extension happens due to the injury to the lateral band, okay, injury to the lateral band. Okay, so injury to the lateral band of dorsal distal expansion results in mallet finger. If suppose instead of the lateral band, if the central band gets injured, okay, if the central band gets injured, the proximal interphalangeal joint will go in for a flexion attitude, and the distal interphalangeal joint will be in an extension attitude. So such a deformity is called as an Botinier deformity. Yes, okay. So what we were discussing is the injury to the dorsal distal expansion. If there is an injury to the lateral band where the patient is not able to do extension of his distal phalanx, it results in a deformity called as mallet finger deformity. Whenever the patient is not able to extend his proximal interphalangeal joint due to the injury to the central band, it results in a deformity called as Botinier deformity. Okay, I am clear with this? So yes, a similar kind of deformity is seen in rheumatoid arthritis, where you will have flexion of the distal interphalangeal joint and extension of the proximal interphalangeal joint, and this deformity which you see here is called as a swan neck deformity. So guys, please remember, in rheumatoid arthritis also you see these kind of deformities. Okay, in rheumatoid arthritis of the hand you see these kind of deformities. What are the deformities you see in rheumatoid arthritis of the hand? You see swan neck deformity, okay, you see Botinier deformity, also you see another deformity called as Z deformity of the wrist. So these are certain deformities which you will see in rheumatoid arthritis. Rheumatoid arthritis, as you all know, it is an inflammatory arthritis. It affects the small joints of the hand. When it affects the small joints of the hand, it can classically result in these kind of deformities: swan neck deformity, Botinier deformity, and Z deformity. Usually mallet finger deformity is not seen in rheumatoid arthritis. Okay, it is due to the avulsion of the attachment of the extensor digitorum tendon at the distal phalanx. Okay, so please be clear in this. It is due to the avulsion of the extensor digitorum tendon at the distal phalanx that results in mallet finger. Okay, so these deformities are called as the deformities of the hands in rheumatoid arthritis. Okay, so with this basis we'll go to the next part, that is the extensor retinaculum. Since we were discussing about the extensor muscles, we'll just add few more points related to the extensor muscles. See, when you see the extensor muscles here, these muscles, when they cross the wrist, they pass through a fibrous tunnel, and this tunnel is called as the extensor retinaculum, Similarly, on the volar aspect also, on the anterior aspect also, the flexor muscles, when they cross the wrist, they pass through a tunnel which is called as a flexor retinaculum. Here it is called as the extensor retinaculum. On the dorsal side it is called as the extensor retinaculum. If I make a cross section of the wrist here, and if I see, I can able to see the following bones. Okay, one on the lateral side will be the radius. Okay, this will be the radius, and on the medial side I have a small bone, that is the head of the ulna, that is the head of the ulna. So this will be my lateral side, so this is radius bone, and the medial side will be the ulna. Okay, so this will be the medial side. You have an elevation here. Can anybody tell me what is the elevation, and on the distal radius where you see the elevation, on the volar aspect or on the dorsal aspect? Anybody? So when you see an elevation in the distal radius, you see the elevation on the anterior aspect of the radius or on the posterior aspect of the radius? Anybody? I'm waiting for the answers. 1 second, 2 seconds. Yes. So if you see an elevation here, this elevation is called as Lister's tubercle. This is called as Lister's tubercle. So please remember guys, Lister tubercle is present on the posterior aspect. It is present on the posterior aspect of the distal radius. It is present on the posterior aspect of the distal radius. Okay, I am making a section of the distal radius and the ulna and its distal aspect. When I make a section, I see a elevation. When I see a elevation, I see that elevation on the posterior aspect of the distal radius, and that elevation is nothing but the Lister's tubercle. That elevation is nothing but the Lister's tubercle. Now there is an modification of the D fascia which is seen in this region, and it is attached to the distal radius, and it is running to the medial side, and it is not attached to the ulna. Instead it is attached to the pisiform bone. Okay, in the wrist you get a bone called as a pisiform bone. So it is attached to the pisiform bone. So please remember, the extensor retinaculum is not attached to the ulna. Extensor retinaculum is not attached to ulna. Okay, is not attached to ulna. If it is attached to ulna, then you will not be able to do this movement which is called a supination and pronation. If two bones are connected by a fibrous band, you will not be able to rotate the band. Okay, so you cannot do supination and pronation. So please remember, the extensor retinaculum is laterally attached to the radius, but medially it is not attached to the ulna. Okay, now this extensor retinaculum is divided into 6 compartments. It is divided into 6 compartments. Okay, so the first compartment is here, the second compartment, third compartment, fourth, fifth, and the sixth compartment. So you have got 6 compartments here. Now what are the muscles which are running in these compartments? So in the first compartment you have got 2 muscles. In the second compartment you have got 2 muscles. In the third compartment you have got only 1 muscle, and in the fourth compartment you have got 4 tendons. Okay, along with another 3 structures. Okay, so a nerve and then artery here, and a nerve and a artery here. Okay, and here you have gotten another tendon in the 5th compartment. In the 6th compartment you have gotten another. Now what are the tendons? So how many compartments are there? There are totally 6 compartments in the extensor retinaculum. And the first compartment, okay, so this is the first compartment. So this is the first compartment. In the first compartment you have got 2 tendons. So one is called as an abductor pollicis longus tendon, another one is called as an extensor pollicis brevis tendon. So please remember guys, these 2 tendons are always like friends, they go close together. Okay, one is called as an abductor pollicis longus tendon, another one is called as an extensor pollicis brevis tendon. So the next tendon what you see here is the extensor carpi radialis longus tendon and extensor carpi radialis brevis tendon. Okay, this is called as extensor carpi radialis longus tendon and extensor carpi radialis brevis tendon. So the next that is the third compartment contains the extensor pollicis longus tendon. Okay, so pollicis is thumb. Okay, extensor pollicis longus is the muscle which is going to the distal phalanx. Okay, so it is coming from the extensor deep compartment. It turns around the Lister's tubercle. If somebody asks you what is the muscle which is turning around the Lister's tubercle, so this muscle turns around the Lister's tubercle. Okay, so it uses the Lister tubercle. It uses the Lister tubercle as a pulley to change its direction, to change its direction. Okay, so the listed tubercle, what is the muscle that is closely related to the listed tubercle? If somebody asks you, the answer is extensor pollicis longus muscle. Okay, extensor pollicis longus muscle. Now coming to the fourth compartment, as we said, it has got four structures. The four structures are, one is the extensor digitorum communis muscle, then extensor indicis muscle, and what you see here is the anterior interosseous artery, and what you see here is the posterior interosseous nerve, So fourth compartment, four structures: extensor digitorum communis, extensor indicis, posterior interosseous nerve, and anterior interosseous artery. Anterior interosseous artery runs on the front of the forearm. Okay, it pierces the interosseous membrane, comes to the back of the forearm, that is anterior interosseous artery. Now fifth compartment, it has got extensor digiti minimi, and the sixth compartment has got extensor carpi ulnaris. Okay, so you got 6 compartments and you got various tendons in these compartments. Of these 6 compartments, what is the most important compartment? What is the one which goes more in for pathology? Is the first compartment. Okay, so you got first compartment. So if you have got tenosynovitis, of the tendons, okay, tenosynovitis of the tendons in the first compartment, then it is called as decurvin tenosynovitis. So if somebody asks you what are the tendons or what are the tendon sheaths that are inflamed in decurvin tenosynovitis, the answer is abductor pollicis longus and extensor pollicis brevis, the straightforward answer. Now what are these two tendons? These two tendons are going to the thumb. Okay, in who these tendons get inflamed or tendon sheaths gets inflamed? The person who uses their hands, like an bus conductor who uses ticket frequently, so for whom the thumb action is important, or for a musician or for a weaver who uses the thumb frequently, those who works more with fine tuning of the hand, these tendons will get inflamed. These tendons are crossing through the first extensor retinaculum. This inflammation results in pain in this region. This is called as what? This is called as decurvin tenosynovitis. Now you ask the patient to keep the finger within his palm, closes his fist and do ulnar deviation. You cause a stretching of the first extensor compartment. When you cause a stretching of the first extensor compartment, it causes severe pain in decurvin tenosynovitis, and this test is called as Finkelstein test. So what is decurvin tenosynovitis? Inflamed sheaths of extensor pollicis longus and brevis is called as decurvin tenosynovitis. And when you do ulnar deviation with the thumb in this attitude, this test is called as Finkelstein test. This test is called as what? Finkelstein test. Okay guys, see, very simple. This condition is frequently seen in ortho OPDs. Okay, so when a patient comes with decurvin tenosynovitis, the initial treatment will be NSAIDs. Then you can try physiotherapy, physio in the form of splints, or heat therapy you can give. If the inflammation is not subsided, you can give steroid injections in the first compartment. If it is not relieved, you can do an DQ release, decurvin tenosynovitis release. We call it as, we can also do a DQ release. So please remember guys, this is again an applied aspect questions. A patient, a manual worker who uses his thumb frequently, comes with pain in the dorsum of the wrist. You do this kind of maneuver which is called as in Finkelstein test. He gets pain in this. What is the condition? Decurvin tenosynovitis. These are the treatment options guys. Okay, so with this we'll move to the next topic. Okay, so next area which is related to the extensor tendon is this anatomical snub box area. Okay, this is a very favorite questions for the UG students. During the exams, the examiners will ask, what is this area, so when you see the when you see my wrist here, I can able to see a fossa here. This fossa is called as anatomical snub box. Okay, usually in olden days, in way back in the eras, so they used to keep the snuffs here, and they they inhale, so they are called as anatomical snuff box. So anatomical snuff box has got certain boundaries, so we'll just see the boundaries of anatomical snuff box. So the boundaries of the anatomical snuff box are, okay, on the lateral side. On the lateral side, it is bounded by two tendons again, that is the abductor pollicis longus tendon and extensor pollicis brevis tendon, which are the tendons of the first extensor compartment. On the medial side, you got one tendon that is called as extensor pollicis longus tendon, one tendon that is extensor pollicis longus tendon. So these are the boundaries of the anatomical snuff box. Now this anatomical snuff box has got a roof, and this roof is made of skin, and you know superficial fascia and deep fascia, okay, superficial fascia and deep fascia. I'm not going into that. Main is in the roof runs a cephalic vein. In the roof runs a cephalic vein, and in the roof runs an important branch of radial nerve, that is a superficial branch of radial nerve. Okay, superficial branch of radial nerve is purely sensory. Yes, purely sensory. Guys, please remember, superficial branch of radial nerve is purely sensory. Now if you tie a watch around this region, around the wrist watches, we wear wrist watches. When we wear wrist watches, it is a superficial branch of radial nerve which is closely running to the anatomical snuff box, gets compressed. It results in a condition called as chiralgia paresthetica. So there is a condition called as chiralgia paresthetica. So what is called as chiralgia paresthetica? Compression of the superficial branch of radial nerve. Compression of the superficial branch of radial nerve at the wrist results in numbness over the first web space. Is called as chiralgia paresthetica. You got various compression neuropathies. There are various compressive neuropathies. We'll discuss about the compressive neuropathies when we come to the median nerve. We have got an important topic there. So at this junction, just know about chiralgia paresthetica. What is chiralgia paresthetica? Compression of the superficial branch of radial nerve, resulting in loss of sensation in the first web space. On the dorsum aspect is called as chiralgia paresthetica. Okay, so this is about the roof of the anatomical snuff box. Coming to the floor of the anatomical snuff box. In the floor of the anatomical snuff box, you got the following bones. Okay, you got the radial styloid. Okay, and you got the scaphoid bone. And you also have the base of, okay, you got the trapezium. And you got the base of first metacarpal bone. More important than these two bones, radial styloid and the scaphoid bone, are the two important bones which forms the floor of the anatomical snuff box. Okay, so you can see all those things in this picture. So you can see the extensor pollicis brevis and abductor pollicis longus tendon forming the lateral boundary, extensor pollicis longus tendon forming the medial boundary. Running on the roof is the cephalic vein, and they have missed a nerve here, which is the superficial branch of radial nerve. Okay, and what is the content? Okay, the content of this anatomical snuff box is nothing but our radial artery. Content is radial artery. So there was a question in NEET. Okay, so a patient sustained a stab injury in the anatomical snuff box. All of the following structures are injured except, so they have given radial artery, they have given superficial branch of radial nerve, they have given cephalic vein, and they have given deep branch of radial nerve. So the answer for that is deep branch of radial nerve, which is not coming into this area. So please remember, this is one of the potential area where questions can come. So anatomical snuff box. So these are the boundaries of the anatomical snuff box. Okay, so content of anatomical snuff box is radial artery. Okay, so I hope you understood what is the anatomical snuff box. The clinical significance of anatomical snuff box. What is the clinical importance of anatomical snuff box? The clinical importance of anatomical snuff box is if you have got tenderness in the anatomical snuff box. So if you have tenderness in anatomical snuff box, okay, if you have got tenderness in anatomical snuff box, so it is a sign of a common carpal bone fracture, that is the scaphoid fracture. Okay, if a scaphoid has got fractured, Okay, please remember, you will have tenderness in the anatomical snub box. So this is the clinical implication of anatomical snub box. Okay, so sometimes if you have got a fall on an outstretched hand, which is, we call it as a foosh injury. Okay, so you have tenderness in the anatomical snub box. If the patient has got tenderness in the anatomical snub box, so then you can think of scaphoid fractures. You can think of scaphoid fracture. That is the importance of this anatomical snub box, this anatomical snub box. Okay, clear? I think we have done with these second compartment. Okay, you know about the first compartment, that is this two muscles which forms the first compartment. So just a small brush up. Second compartment contains extensor carpi radialis longus and extensor carpi radialis brevis. Third compartment contains extensor pollicis longus. Fourth compartment contains extensor digitorum communis, extensor indicis. You have got an anterior interosseous artery and posterior interosseous nerve. And the fifth compartment contains the extensor extensor digiti minimi and extensor carpi ulnaris is in the sixth compartment. So this is just to fill up the blank space which were given here. This is just to fill up the blank space which is given here. Okay, so this is about the various parts of the extensor retinaculum. Okay, now we'll come to the next topic, median nerve. See guys, very important. So next two nerves, one is the median nerve, another one is the ulnar nerve. Very important topic. So just to begin with, okay, we'll see where the median nerve is arising and how it is coursing through the upper limb. See, to understand this, we'll just draw a very simple diagram and we'll see what are the important areas which are crossed by this now. Okay, so this is the arm, as you know, this is the greater tubercle and this is the shaft of the humerus, and this shaft of the humerus at the end forms the lateral condyle, okay, capitulum and the trochlea and the medial condyle. Okay, so you can see the distal part of the humerus, and you all know that the capitulum articulates with the radius. Okay, so this is the radius bone. Okay, so the radius, the lower end is broad compared to the ulna, whereas the ulna, the upper end is broad compared to the radius. Okay, so this is the ulna. So you can see the ulna bone here. Okay, fine. So coming to the distal part of the upper limb, so you will have the carpal bones here. So you have the two rows of carpal bones and you got the metacarpals here. You got the metacarpals here. You got the metacarpals here. So this is a simple schematic diagram of the upper limb to understand the course of the median nerve. See, as you all know, there is an artery which is running in the axillary region. This artery is called as the axillary artery. You all know that. If there is a cord which is running on the lateral side of the axillary artery, it is called as the lateral cord. If there is an artery which is running on the medial side, it is called as the medial cord of the brachial plexus. So what are these cords? This cord is called as the lateral cord of the brachial plexus. This is called as the lateral cord of the brachial plexus, and this is called as the medial cord of the brachial plexus. Medial cord of the brachial plexus. See, these two cords gives rise to two branches. One is called as the lateral root of the median nerve. So one is called as the lateral root of the median nerve. Okay, so we will just use a different color, guys, here. Yes, so one is called as the lateral root of the median nerve, and the medial cord gives rise to medial root of the median nerve. Both of them fuse to form the median nerve. Both of them fuse to form the median nerve. You can get a M-shaped arrangement of the nerves of the brachial plexus at this point. You can see there is an M-shaped arrangement. Okay, you can able to see an M-shaped arrangement of the nerves at the brachial plexus. So what is this root? This root is the lateral root of the median nerve. This root is the lateral root of the median nerve. And what is this root? This root is the medial root of the median nerve. This root is the medial root of the median nerve. Now both of them fuse to form the median nerve, and the median nerve, after its formation, how it runs? It runs on the lateral aspect of the brachial artery. So the axillary artery, as you all know, it continues as brachial artery. Can anybody tell me at what level the axillary artery continues as brachial artery? Anybody from the audience? Anybody? At what level the axillary artery continues as the brachial artery? I hope you guys would have been studying. I'm just expecting few answers. Yes, anybody? Yes. See, you know that there is a muscle which is very good here. So there is a muscle which is here. This is called a teres major muscle. From the lower border of the teres major muscle, we call this artery as the brachial artery. So the axillary artery continues as the brachial artery from the lower border of the teres major. So this is brachial artery, and this brachial artery, as it runs, into the cubital fossa. At the level of the neck of the radius, it divides into two branches, radial artery and ulnar artery. Radial artery and ulnar artery. And if you see the median nerve was coursing on the lateral side of the brachial artery. It is coursing on the lateral side of the brachial artery, approximately at the middle of the arm, or we can say approximately at the level of insertion of the coracobrachialis, where lot of changes takes place in the arm. This median nerve also crosses the brachial artery from the lateral to the medial side. There is a change in the course of the median nerve at the middle of the arm. So at that time it was running on the lateral side, it crosses and comes to the medial side. So it runs on the medial side of the arm in the lower half of the arm. It runs on the medial side, it runs and enters a fossa called as cubital fossa. I hope you all know that there is a fossa here that is bounded by brachioradialis and that is bounded by pronata teres. And what is this fossa? This fossa is called as the cubital fossa. This fossa is called as cubital fossa, and the nerve enters the cubital fossa. When it enters the cubital fossa, it sees a muscle in between. It is obstructing the course of the nerve. So this muscle is nothing but the pronata teres muscle. So what is this muscle? This muscle is called as pronata teres muscle. Now how many heads pronata teres muscle has got? It has got two heads. I hope you know what are the two heads. One is called as the humeral head and another one is the ulnar head. It has got two heads. Now the nerve passes in between the two heads of the pronata teres muscle. Okay, it passes in between the two heads of the pronata teres muscle. Yes, it passes in between the two heads of the pronata teres muscle. Very important, guys. Very important. You can see here the nerve is passing between the two heads of the pronata teres muscle. And also remember, there is an artery which is running here. This is the ulnar artery. This is what? This is ulnar artery. Now the median nerve is separated from the ulnar artery by the deep head of pronata teres. This is slightly a complex relationship. If you understood, it is very good. Otherwise, don't worry about it. At this junction, what you have to remember is median nerve passes between the two heads of pronata teres. So keep this in mind. Now after crossing the pronata teres muscle, it reaches the proximal aspect of the forearm, where it runs beneath another arch, another tendinous arch. Okay, so this tendinous arch which is noted here is the flexor digitorum superficialis muscle. So what is this muscle? This muscle, what you see here, is flexor digitorum superficialis muscle. Now it runs beneath this muscle. When it runs beneath this muscle, it also gives a branch on the lateral side. The branch which is given by the median nerve here is called as the anterior interosseous nerve. What is AAN stands for? It is called as anterior. Okay, anterior interosseous nerve. It is called as anterior interosseous nerve. Okay, so guys, please remember. So the median nerve, when it runs in the forearm, it gives a branch on the lateral side, and that lateral branch is called as anterior interosseous. Now somebody asks you, anterior interosseous nerve is a branch of median nerve. So suddenly they will ask you, posterior interosseous nerve is a branch of radial nerve. Posterior interosseous nerve is a branch of radial nerve, which is also the deep branch of the radial nerve. So deep branch of the radial nerve is also called as the posterior interosseous nerve. Now guys, please listen here. Please watch here. What happens to the median nerve further? This median nerve, after running through the forearm, okay, it comes to the wrist. In the wrist, it crosses a retinaculum. This retinaculum is called as the flexor retinaculum. So it runs deep to the flexor retinaculum. So what is this retinaculum? This is called as flexor retinaculum. And it runs deep to the flexor retinaculum. And what is the tunnel called as? The tunnel which is deep to the flexor retinaculum is called as carpal tunnel. It is called as carpal tunnel. Okay, it is called as carpal tunnel. When it runs in the forearm, it also gives a cutaneous branch. Which is called as the palmar cutaneous branch, which is running above the flexor retinaculum. So please remember, palmar cutaneous branches to the hand from the median nerve, palmar cutaneous branch. Okay, so this is called as palmar cutaneous branch to the hand. Okay, palmar cutaneous branch to the hand of median nerve runs superficial to flexor retinaculum. mediano runs deep to flexor retinaculum, but its palmar cutaneous branch runs superficial to flexor retinaculum. So keep this in mind. Now when the mediano passes across the flexor retinaculum, it enters the palm, divides into branches and supplies the skin and the muscles of the palm region. We will see about those when we come to the branches now. Okay, clear? So this is the course of the mediano. Okay, so just see what is happening to the mediano. Mediano arises from the lateral root of mediano. It is arising from the lateral root of mediano and from the medial root of the mediano. They arise from the lateral cord and the medial cord respectively. They fuse in the formation of M. They form a pattern of M there. After that, the nerve initially runs on the lateral aspect of the brachial artery. So what is this artery? This artery is brachial artery. So initially it runs on the lateral side of the brachial artery. And what is this muscle we saw? This muscle is teres major muscle. Okay, after crossing the middle of the arm, it crosses the brachial artery from the lateral side to the medial side. Then it runs on the medial side of the brachial artery in the cubital fossa. It passes between the two heads of the pronator teres, reaches the forearm. In the forearm, it gives a branch called as anterior interosseous nerve. It gives a branch called as palmar cutaneous branch of the median nerve. Then it runs beneath the carpal tunnel or through the carpal tunnel beneath the flexor retinaculum and finally reaches the palm. So see, only when you understand the areas where it is crossing, you can able to understand a lot of things here. I'll just come back to the nerve lesions when we talk about those. Before that, what are the branches which are, or what are the muscles which are supplied by the mediano, and what are the sensory area which is supplied by the mediano? We'll see. If you want to understand that, okay, so you have to understand the muscles of the forearm. Okay, we have to understand the muscles of the flexor aspect, of the forearm. So we are just discussing the muscles of the flexor aspect of the forearm. So what is flexor aspect? I hope you know what is called as the, so this is the flexor aspect, guys, and this is the extensor aspect. This is the extensor aspect. Now when you see the flexor aspect, the muscles in the flexor aspect of the forearm are arranged in 3 layers. Are arranged in how many layers? They are arranged in 3 layers. Okay, so we'll just see what are the muscles here. So the muscles of the flexor aspect of the forearm are arranged in 3 layers. One is called as the superficial group. Next is called as an intermediate group. The next one is called as the deep group. Okay, in the superficial group you have got 4 muscles. One is called as the pronator teres muscle. See, I am writing in short form for the sake of time. So you should not write like this. So you understand the muscles. So one is called as pronator teres. Next one is called as flexor carpi radialis. Next one is called as palmaris longus, and the last muscle is flexor carpi ulnaris. These are the 4 muscles in the superficial layer of the flexor aspect of the forearm. Okay, the next muscle in the area is flexor digitorum superficialis muscle. So the intermediate layer is formed by flexor digitorum superficialis, and the deep group is formed by flexor digitorum profundus, flexor pollicis longus, and pronator quadratus. So these are the muscles of the flexor aspect of the forearm. Okay, guys. So if you take these muscles, these muscles have got their specific origin and insertion. To keep it very simple, okay, most of the muscles, have gotten common tendinous origin from the medial epicondyle. Okay, so from the medial epicondyle they have got a common tendinous origin. Okay, so this common tendinous origin from the medial epicondyle is called as the flexor origin. So most of the muscles, they take their origin from the medial epicondyle. So keep it very simple. We can keep it like this. They originate from here and they go to the various aspect of the forearm and they cause specific actions. Okay, so it is not that important to deal with the insertions and the origins now. So we'll just add here and there when we reach those muscles and whatever is important to those things. Okay, see, when you see the superficial group of muscles, there is pronator teres muscle, and the pronator teres muscle, as you all know, it has got 2 heads. We just discussed about the 2 heads, and it gets inserted into the middle of the shaft of the radius. And what is the action of pronator teres? It causes pronation, it causes pronation, okay. Flexor carpi radialis causes flexion of the wrist, okay. Along with the extensor carpi radialis, it will cause adduction of the wrist, okay. Palmaris longus will cause tightening of the palmar aponeurosis. Flexor carpi ulnaris will causes flexion of the wrist, and along with the extensor carpi ulnaris, it will cause abduction of the wrist, okay. So these are few actions, so don't worry about this. I'll just show the muscle and I'll explain you easily, okay. So when you see these muscles, okay, so the muscle what you see here, which has got two heads, one from the humeral head, okay, and another from the ulnar, is the pronator teres muscle. So what you see here is the pronator teres muscle. This pronator teres muscle gets inserted into the shaft of the radius. It is inserted into the shaft of the radius, okay, clear. It is inserted into the shaft of the radius. And in a more distal part, if you see, there is another muscle which is called as pronator quadratus, okay, pronator quadratus. This pronator quadratus takes origin from the ulna, okay, it takes origin from the distal ulna and gets inserted into the distal radius, okay. What is the action of these two pronators? They causes pronation, okay. So pronator teres and the pronator quadratus, both of them they cause pronation, okay, fine. So now coming to the next muscle, this muscle which is marked here is flexor carpi radialis, okay. So as you all know, flexor carpi radialis gets inserted into the base of second and third metacarpal. Yes, this muscle will cause flexion of the wrist. When it acts along with extensor carpi radialis longus and brevis, it causes abduction of the wrist. So guys, please remember, okay, so wrist, okay, when the flexor carpi radialis acts, it causes flexion of the wrist. When it acts along with the extensor carpi radialis longus and brevis, it causes abduction of the wrist, okay. So this muscle what you see here is the palmaris longus muscle. This is palmaris longus muscle, which forms the palmar aponeurosis, and the muscle what you see here is called as a flexor carpi ulnaris muscle. Flexor carpi ulnaris muscle goes and gets inserted into the pisiform bone. It is where it gets inserted, and this flexor carpi ulnaris muscle action is, it causes adduction of the wrist and it also causes flexion of the wrist. Sorry guys, it causes adduction of the wrist and it also causes flexion of the wrist. So that is the action of flexor carpi ulnaris. So when you lift these muscles, these are the superficial group. When you lift these muscles, you will see the next muscle which is called as the flexor digitorum superficialis muscle. So please pay attention to this muscle. Understanding of this muscle, insertion of this muscle is important. Flexor digitorum superficialis muscle, it takes origin from the humerus and from the ulna and from the radius. It has got a wide origin. Insertion is when it comes to the wrist, it splits into 4 tendons. It goes to the medial 4 fingers. Guys. When it goes to the medial 4 fingers, when it crosses the metacarpophalangeal joint, it splits into two. And gets attached to the base of the middle phalanx, okay. So for a schematic representation, I'll just draw a small picture here. So this represents the metacarpal bone, this represents the proximal phalanx, this represents the middle phalanx, and this represents the distal phalanx, okay. So if you see the flexor digitorum superficialis tendon, it splits into two, okay. It splits into two when it crosses the metacarpophalangeal joint and gets inserted into the base of the middle phalanx. So what is this? This is metacarpal, this is proximal phalanx, this is middle phalanx, and what is this? This is distal phalanx. So now this tendon which is splitting into two and getting inserted onto the either side of the middle phalanx is what? This is flexor digitorum superficialis muscle. Now what are these four tendons goes? These 4 tendons goes to the medial 4 finger, guys. And what is their action? See, very simple. Whatever the joints which are crossed by the muscle will act on those joints, okay. So but ultimately its main action is on the distal part where it is getting attached. So this muscles when it acts, it causes flexion of the proximal interphalangeal joint. It causes flexion of the proximal interphalangeal joint. Okay, so I'm just flexing my proximal interphalangeal joint. I hope it is clear. So the flexion of the proximal interphalangeal joint is produced by the flexor digitorum superficialis muscle. This is very important. Okay, this is very important. So next, coming to the deep layer muscles, what they have marked here is flexor digitorum profundus muscle. Flexor digitorum profundus muscle. Okay, this flexor digitorum profundus muscle arises from the ulna and from the interosseous membrane. It splits into 4 tendons again to the medial 4 fingers. Okay, to color or to differentiate it, I will use a blue color here. So flexor digitorum profundus runs beneath the flexor digitorum superficialis. It passes in between the 2 slips. It passes in between the 2 slips and gets attached to the distal phalanx Okay, so I think it is clear, guys. So the flexor digitorum profundus goes and gets attached to the distal phalanx. So when it acts, it causes flexion of the distal interphalangeal joint. It causes flexion of the distal interphalangeal. So if you want to elicit the action of flexor digitorum profundus, you need to stabilize the middle phalanx, and then you ask the patient to flex his fingers. So when he flexes his fingers, only the distal phalanx acts here now. So distal phalanx flexion is produced by flexor digitorum profundus. Flexor digitorum profundus. Okay, the flexor pollicis longus goes and gets inserted into the distal phalanx of the thumb. So it causes flexion of the interphalangeal joint of the thumb. In thumb, you don't have middle phalanx, you don't have proximal interphalangeal joint, you don't have distal interphalangeal joint. Here there is only interphalangeal joint. Flexor pollicis longus causes flexion of the distal, or it causes flexion of the distal phalanx, or in other words, it causes flexion of the interphalangeal joint. It causes flexion of the interphalangeal joint. You can see that very clearly here. So the muscle goes to the distal phalanx and it causes flexion of the interphalangeal joint of the thumb. It causes flexion of the interphalangeal joint of the thumb. So please remember flexor pollicis longus. Only when you remember flexor pollicis longus action, you will understand an important sign in the ulnar nerve. You will understand an important sign in the ulnar nerve. Okay, so please have a note of it. Okay, so these are the muscles of the forearm. So as we have discussed, the muscles of the forearm are grouped into superficial, middle and deep layers. So what they have given here is the actions now. So pronata teres, yes, we have discussed it. So it causes pronation. It causes pronation of the forearm. It causes pronation of the forearm. Okay, the action of flexor carpi radialis is the action of. Okay, so we have seen about those muscles. Now their actions, I think we can easily say now. So pronata teres causes pronation of the forearm. Flexor carpi radialis causes 2 functions. Okay, one, it causes the flexion of the wrist. It causes flexion of the wrist. It also causes abduction of the wrist when it acts along with the extensors. It acts along the extensors. Okay, palmaris longus, it tightens the palmar aponeurosis. It tightens the palmar aponeurosis, and it also causes flexion of the wrist. It also causes flexion of the wrist. It also causes flexion of the wrist. Okay, flexor carpi ulnaris, yes, it causes flexion of the wrist. It causes flexion of the wrist. Along with that, it can also cause adduction of the wrist. Adduction of the wrist when it acts along with extensor carpi ulnaris. When it acts along with extensor carpi ulnaris, it causes adduction of the wrist. It causes adduction of the wrist. So please remember flexor digitorum superficialis. It mainly causes flexion of the wrist. It causes flexion of the metacarpophalangeal joint. It mainly causes flexion of PIP, proximal interphalangeal joint. Flexor digitorum profundus causes flexion of distal interphalangeal joint. Causes flexion of distal interphalangeal joint, and flexor pollicis longus causes flexion of the interphalangeal joint of the thumb. Interphalangeal joint of the thumb is mainly flexed by flexor pollicis longus. And pronator quadratus, the name says, okay, it is called as the watch muscle. It causes pronation of the wrist. It causes pronation. Okay, it causes pronation of the wrist. It causes pronation of the forearm. Okay, it causes pronation of the forearm. Okay, so these are the muscles which are in the forearm, in the flexor aspect, and their action. Nerve supply. See, the nerve supply is very simple, guys. Most of the muscles of the forearm are supplied by the median nerve or a branch of the median nerve, except okay, flexor carpi ulnaris and medial of a flexor digitorum profundus, except by flexor carpi ulnaris and medial half of flexor distal profundus, they are supplied by ulnar nerve. So pronator teres, yes, we have seen that this is supplied by median nerve, this is supplied by median nerve. Flexor carpi radialis, yes, it is supplied by median nerve. Palmaris longus, yes, it is supplied by median nerve. Flexor carpi ulnaris, as we have told, it is supplied by ulnar nerve. It is supplied by ulnar nerve. Okay. Flexor distal superficialis by median nerve. Flexor distal superficialis by median nerve. Flexor distal profundus lateral half by anterior interosseous nerve, which is a branch of median nerve. So please remember, it is a branch of median nerve, and the medial half of flexor distal profundus. Medial half of flexor distal profundus is supplied by ulnar nerve. Flexor pollicis longus is supplied by anterior interosseous nerve. It is a branch of median nerve. Pronator quadratus is supplied by anterior interosseous nerve, which is a branch of median nerve. So please remember, guys, these are very important muscles and important nerve supply. Only when you understand the nerve supply and their action, when the nerve is cut or when the nerve undergoes a lesion, then you will able to identify the lesion by examining the muscle. So for that it is very important. Okay, so these are the muscles. To put it very simply, all the muscles of the forearm are supplied by median nerve except flexor carpi ulnaris and medial half of flexor distal profundus, which is supplied by ulnar nerve. All the other muscles are supplied by median nerve or by their branches. Okay, so this is about the muscles in the forearm. This is about the muscles in the forearm. Okay, now when the median nerve, okay, when the median nerve reaches, okay, when the median nerve reaches the hand, okay, when the median nerve reaches the hand, what happens to the median nerve in the hand? See, just we'll see a simple diagram here. Okay, so when the median nerve reaches the hand, so let us consider this is the thumb, this is the index finger, this is the middle finger, this is the ring finger, and this is the little finger. Okay, so you know that there is a retinaculum which is here, which is called as the flexor retinaculum. Beneath the flexor retinaculum you get a tunnel that is called as the carpal tunnel, and the median nerve enters beneath the carpal tunnel or enters through the carpal tunnel. It enters the palm nerve. In the palm it divides into two branches. One is called as the recurrent branch. Okay, one is called as a recurrent branch, and then the further branch divides into a proper digital branch and three common digital branches. So what are these? So in the hand it gives a recurrent branch, okay, then it gives a proper digital branch. It is called as a proper digital branch. Then it gives three common digital branches. Then it gives rise to three common digital branches. These are called as the common digital branches. This common digital branches splits into two proper digital branches and supplies the adjacent side of the index finger, middle finger and the ring finger. Okay, clear? So these nerves supplies 3 fingers. Okay, so they mainly supply sensation to the hand. So the sensation to the hand on its lateral 3 fingers is supplied by the median nerve. Now what is this recurrent branch doing? This recurrent branch supplies the muscles of the thenar region. Okay, and the common palmar digital branches gives rise to the motor branches of the first and second lumbricals. So the first and second lumbricals are supplied by the common palmar digital branches. So please remember, in the hand the median nerve supplies, okay, the flexor pollicis brevis, the abductor pollicis brevis, and it also supplies the opponens pollicis. So these three muscles are the thenar group of muscles which are supplied by the recurrent branch of the median nerve, Okay, so guys, please remember, flexor pollicis brevis has got a deep head, and this deep head is supplied by the ulnar nerve. Whereas the superficial head is supplied by the recurrent branch of the median nerve. Okay, so you can also see the lumbricals here, the lateral two lumbricals, which are also supplied by the median nerve. So in the hand the lateral two lumbricals, the three muscles of the thenar region, namely the opponens pollicis, the flexor pollicis brevis, and the abductor pollicis. And the abductor pollicis are supplied by the median. Okay, and the sensory supply to the palm is the lateral three end of fingers. So the lateral three end of fingers is by the median, and this median don't stop here. It goes to the dorsal aspect also, and it supplies the dorsum of the lateral three end of fingers up to the level of the middle phalanx, okay. So this is about the supply of the median. This is how the median supplies in the forearm and in the palm region. See, we have discussed about the muscles of the forearm. Just to add few points about the muscles of the thumb or muscles of the hand region. So if you see here, there is a muscle called as abductor pollicis brevis. You can see a muscle here called as abductor pollicis brevis. Now what is the function of abductor pollicis brevis? The function of abductor pollicis brevis is to cause abduction of the thumb like this. This is called as abduction of the thumb. You take the thumb away from the plane of the palm. This is called as abduction. When you bring it back, this is called as adduction. So what is this action? This is called as abduction of the thumb. Okay. Now when you take the thumb across the palm, this is called as the flexion of the thumb. This is called as flexion of the thumb, and this is called as the extension of the thumb. This is called as flexion of the thumb, and this is called as extension of the thumb. Okay, and this is called as the opposition of the thumb. This is called as opposition of the thumb. See, suppose if the median nerve is not working, what happens? I cannot able to abduct my palm like this. My palm goes into an adduction. I cannot flex also. It goes into an extension and adduction attitude. This kind of hand is called as an ape thumb deformity. This kind of deformity is called as an ape thumb deformity. Okay, this kind of deformity is called as an ape thumb deformity. And also remember lumbricals. So median supplies the lateral two lumbricals. Median supplies the lateral two lumbricals. Please remember the function of the lumbricals. So function of the lumbricals is it causes extension of the interphalangeal joints, and it causes flexion of the metacarpophalangeal joint. So what do I mean by that? If I keep my hand like this, if I keep my hand like this, I have got flexion at the metacarpophalangeal joint, and I have got extension at the interphalangeal joints, and I got extension at the interphalangeal joint. So I got flexion at the metacarpophalangeal joint, and I got extension at the interphalangeal joint. So this action is the action of the lumbricals. So if you draw a letter L, you can draw a letter L here. So this L stands for lumbricals. L stands for lumbricals. L stands for the action of the lumbricals. Okay, it causes the metacarpophalangeal joint flexion and extension of the interphalangeal joint. If the lumbricals doesn't work, what happens to the metacarpophalangeal joint? Metacarpophalangeal joint goes in for extension and interphalangeal joint goes in for flexion. It results in a classical hand called as claw hand. It results in a classical hand called as claw hand. Okay, so please remember. So what is this? So this is the action of the lumbricals: flexion of the metacarpophalangeal joint, extension of the interphalangeal joint. When the lumbricals doesn't work, so the opposite happens: extension of the metacarpophalangeal joint and flexion of the interphalangeal joint. So this is called as clawing. This is called as clawing. So this is like a claw of a bird. So it is called as claw hand. So when median nerve is not working, when median nerve is injured, or when there is a lesion in the median nerve, the lateral two lumbricals will not work. So the index finger and the middle finger will go in for clawing. So that is called as a partial claw hand. That is called as a partial claw hand. That is called as a partial claw hand. So okay. So please remember, guys. So when the median nerve is not working, you have these kind of problems. Okay. So the patient will also have difficulty in flexion of the fingers. The patient will have difficulty in flexion of the fingers. Okay. So when the median nerve is not working, so the patient will have the lot of deformities and lot of deficiencies in the palm. Okay. So before going into that, okay, we'll just see the muscles supplied by the median nerve in the palm. Okay, it goes by a, see, these are things to remember. Okay, so it goes by a mnemonic called as loaf, or loaf of bread. We say loaf of bread. So this is loaf. L stands for lumbricals. L stands for lumbricals. I hope you know what are the lumbricals. The first and the second lumbricals are supplied by the median nerve. O stands for opponents. O stands for opponens pollicis. A stands for abductor pollicis brevis. A stands for abductor pollicis brevis. A stands for abductor pollicis brevis, and F stands for flexor pollicis brevis. Okay, and what head of flexor pollicis brevis? It is the superficial head of flexor pollicis brevis. It is the superficial head of flexor pollicis brevis, because deep head of flexor pollicis brevis is supplied by yes, it is supplied by D branch of ulna. Now I told about the sensory part also. So the lateral 3 end of fingers, so the lateral 3 end of fingers on the palmar side, and on the dorsal side, the lateral 3 end of fingers up to the middle phalanx, is supplied by the median nerve. This is the sensory supply of the median nerve in the hand region. Okay, so these are the muscles which are supplied by the median nerve. Now suppose a median nerve, when it is running along its course, it can get compressed at various points, okay, resulting in entrapment neuropathies. So if you look into the course of the median nerve, at what are all the parts or what are the areas it can get compressed? See, when it runs in the arm region, it can get compressed by a ligament here. This ligament is called as ligament of Struthers. Okay, so here it can get compressed, or it can get compressed when it crosses the pronator teres, resulting in pronator teres syndrome, or it can get compressed when it runs through the carpal tunnel. So this is called as carpal tunnel syndrome. Okay, so please remember, guys, these are called as entrapment neuropathies. What are called as entrapment neuropathies? So entrapment neuropathies is entrapment neuropathies. So entrapment neuropathies is, so the nerve gets affected due to compression at various sites along its course. So median nerve can get compressed at the ligament of Struthers, or it can get compressed at the pronator teres, resulting in pronator teres syndrome, or it can get compressed on the flexor retinaculum, resulting in carpal tunnel syndrome. Okay, so this is very important regarding the median nerve entrapment syndromes. Okay, we'll just discuss about that in a short while. So just have a look into this picture. Sometimes cadaveric images are given nowadays. Okay, so when cadaveric images are given, so you must be in a position to identify what are all the structures, or what are the nerves which are coming in these areas, or what are the structures. See, they will put a simple arrow and they will ask you what is this. So when you see this is cubital fossa, and this cubital fossa has got a muscle here. So this muscle is called as brachioradialis muscle, and the muscle what you see here is called as a pronator quadratus muscle, pronator teres muscle. So this is pronator teres muscle. Okay, this is pronator teres muscle. They form the boundaries of the cubital fossa, and there is an imaginary line if you draw here. So this triangle which you make out here is called as the cubital fossa. And if you see the cubital fossa, in the roof there was a aponeurosis. This aponeurosis is called as bicipital aponeurosis, and this bicipital aponeurosis was cut here to show you certain structures. So what are the structures you can able to make out? Important structures I will just mark. So this is the radial nerve. Radial nerve in the cubital fossa divides into two. This is the superficial branch. And this branch what you see here, okay, this branch what you see here is the deep branch of the radial nerve. This is called as the deep branch of the radial nerve. And just medial to it you see an artery. The artery which you see here is the brachial artery. And just lateral or just medial to the brachial artery, what you see here is the median nerve. So this is the median nerve. Okay, so in the cubital fossa, the most medial structure is the median nerve. Next comes the brachial artery, and next comes the radial nerve. Okay, so this is about the cubital fossa orientation and the arrangement of the structures in the cubital fossa. They might put an arrow mark in any of these structures and they can ask you what is this. Okay, so please be aware of it. So when you talk about the entrapment neuropathies, okay, so median nerve can get compressed most commonly in an area which is running across the wrist called as the carpal tunnel. Okay, so you are going to see about carpal tunnel syndrome now. Now what is called as carpal tunnel syndrome? Compression of the median nerve in the wrist, okay, through the carpal tunnel where it is running is called as a carpal tunnel syndrome. See, when the when the nerve is running here, okay, after it crosses the carpal tunnel, what are all the areas or what are all the muscles which are supplied by the median nerve will not work. Okay, I hope you know the thenar muscles and the lateral 3 end of fingers receiving sensation and the lateral 2 lumbricals will become weak. Okay, so this patient with the carpal tunnel will have paresthesia, in the lateral 3 end of fingers, and this paresthesia will increase, when you do the following test. So you compress over the median nerve in the carpal tunnel which is already compromised. The paresthesia will worsen in the lateral 3 end of fingers. That test is called as Durkan's test. So Durkan's test is one provocative test. So all these are called as provocative test. So Durkan test is one provocative test. You ask the patient to keep the wrist in palmar flexion. So you are keeping the wrist in palmar flexion. When you keep the wrist in palmar flexion, again the carpal tunnel gets compromised. So when the carpal tunnel gets compromised, the paresthesia worsens. This is called as Phalen's test. This is called as what? This is called as Phalen's test. Durkan's test, Phalen's test are important tests. You can also tap the median nerve along its course. So you will have a tingling sensation, that is called as Tinel sign. So all these are tests to find out carpal tunnel. All these are clinical tests to find out carpal tunnel. Okay, so you can do this test, and of these 3 tests, the most specific test is Durkan's test. Most specific of these 3 tests, the most specific test is Durkan's test. And also remember, whenever there is an carpal tunnel syndrome, okay, please remember the palm will not lose its sensation. Okay, the palm will not lose its sensation. Only the fingers loses its sensation or become it become anesthetized. Can anybody tell me why the palm is not involved in carpal tunnel syndrome? Though the occlusion happens here, the palm is not involved in carpal tunnel. Can anybody reason out why? Yes, guys. So you have been listening the class for the past few hours. Why the palm is not involved in carpal tunnel? Because there is a nerve called as palmar. There is a nerve called as palmar cutaneous branch of median nerve. Palmar cutaneous branch of median nerve which runs outside the carpal tunnel. So it is not involved in carpal tunnel syndrome. So the palmar cutaneous branch is not involved. So the lateral half of the palm is not anesthetized. Only the lateral 3 end of fingers is anesthetized. So this is called as carpal tunnel syndrome. And whenever a patient has got carpal tunnel syndrome, you can confirm it by doing nerve conduction study. Okay, and once a patient has got carpal tunnel syndrome, you can treat by giving NSAIDs. Okay, you can give NSAIDs, you can give splints. Okay, you can give NSAIDs to reduce the pain, you can give splints, you can give steroid injections. Okay, if it is not cured, okay, if the patient has persistent problem, then you can do a carpal tunnel release. Okay, then you can do a carpal tunnel release. So what is the take home message at this junction is, so there is a tunnel in the wrist which is called as carpal tunnel. Beneath or through the carpal tunnel runs a nerve called as median nerve. Median nerve compression in this carpal tunnel results in carpal tunnel syndrome. Okay, so yes, very good. So yes, somebody has answered, Soumya, yes, very good. So it is about the carpal tunnel syndrome. So please remember about the test in the carpal tunnel which are frequently asked questions. One is called as Durkan's test, another one is called as Phalen's test, another is called as Tinel sign. All these are the clinical test for the carpal tunnel syndrome, and of this the most specific test is Durkan's test. Okay, now whenever there is a median nerve lesion, what are the clinical signs the patient will show? As I already told you, the thumb will lose its abduction and flexion. It goes to an primitive form which is called as an ape thumb deformity. So what is this? This is called as an ape thumb deformity. Now because the long flexors of the thumb mainly the flexor digitorum superficialis become weak, and the flexor digitorum profundus to the lateral two fingers becomes weak. Okay, so the patient will have difficulty in flexing the index finger and the middle finger. Okay, so he will not be able to flex it properly. He can able to flex the other two fingers because flexor carpi ulnaris is working, okay, because flexor carpi ulnaris is working, but he will not be able to flex the two fingers here. Okay, so this results in a sign called a sign of benediction. See, we are discussing about the outcomes of the median nerve lesion. So when the median nerve is not functioning, the abduction of the thumb and the flexion of the thumb is lost. You can able to see the thumb going into a primitive position, which is called as an ape thumb deformity. Please remember, when you see this picture, you also see one more finding here. Can anybody tell me what is the finding you see here? What is the finding you see here? Yes, anybody from the audience? What is the finding you see on that marked area? Okay, so that is called as thenar wasting. That is called as thenar wasting. Yes, that is called as thenar wasting. Okay, so you see the thenar muscles going in for wasting in that area. Okay, so we were discussing about the long flexor tendons. Since the flexor digitorum superficialis is not working, okay, so the flexion of the interphalangeal joints become weak. When the flexor digitorum profundus is not working, the lateral, okay, the lateral two fingers, okay, the flexion of the distal interphalangeal also becomes weak. So it results in a classical attitude called as the hand of benediction. It is called as a hand of benediction. You can also do one more test. You ask the patient to clasp his fingers, which is called as Horschner clasp test, which is called as Horschner clasp test. So when you ask the patient to clasp his hand, if my right hand median nerve is not working, the index finger will stand out. Okay, it will point towards you. It is called as an pointing index. So Horschner clasp test. So the index finger will point out. So this is called as an pointing index. This is called as what? This is called as pointing index. So pointing index, hand of benediction, ape thumb deformity are all the findings which you come across in the median nerve palsy. I am not telling about carpal tunnel now. Please remember, I am not telling only about carpal tunnel. As a whole, median nerve, when it gets injured on the forearm or in the elbow or just above the elbow, a total median nerve lesion will have all these signs. So ape thumb deformity, hand of benediction, and when you do an Horschner clasp test, the patient will present you with pointing index. Okay. See, median nerve is again, when you see it, when it crosses the humerus across the elbow, okay, it can get injured in this fracture. Can anybody tell me what is the X-ray showing? Yes, anybody can tell me the diagnosis from the X-ray, guys? Yes, Mugundan. Yes, it is. Yes, Hari. Yes, it is supracondylar humerus fracture. Very good, guys. This is supracondylar humerus fracture. So you all know that supracondylar humerus fracture is very, very common. Okay, supracondylar humerus fracture is very, very common in children's. Okay, so whenever there is a supracondylar humerus fracture, the structure which runs in front of the humerus, so that is brachial artery, okay, which can get injured or which can get trapped by the fracture. So brachial artery injury is common. In supracondylar humerus fracture. Also remember, there is a nerve which runs in front of the humerus, and the branches of the nerve which runs in it, that is the anterior interosseous nerve, can get mostly damaged. So anterior interosseous nerve injury is more common than median nerve injury, in supracondylar humerus fracture. So please remember, whenever there is a supracondylar humerus fracture, anterior interosseous nerve injury is very common. Whenever there is an anterior interosseous nerve injury, anterior interosseous nerve supplies three muscles. One, it supplies the flexor pollicis longus muscle. Okay, flexor pollicis longus muscle. What is the action of flexor pollicis longus muscle? If I want to flex my interphalangeal joint of the thumb, my flexor pollicis longus has to work. Okay, the other muscle is the lateral half of the lateral half of flexor digitorum profundus muscle. So the lateral half of the flexor digitorum profundus muscle goes to these two fingers, and their action causes flexion of the distal interphalangeal joint. Their action causes flexion of the distal interphalangeal joint. So please remember, whenever there is an flexion of the distal interphalangeal joint or of the index finger or the interphalangeal joints of thumb, anterior interosseous nerve has to be intact. Okay, and the next muscle is pronator quadratus muscle, where it helps in the pronation of the forearm. Main muscle is flexor pollicis longus and lateral of a flexor digitorum profundus. When it is not working, okay, so you cannot do interphalangeal joint flexion and you cannot do distal interphalangeal joint flexion here. So if you ask the patient to make a OK sign like this, okay, so this is a proper OK sign, this is a proper OK sign. So where you can see there is a flexion of the distal interphalangeal joint and there is a flexion of the interphalangeal joint of the thumb. This is a proper OK sign. If the anterior interosseous nerve is not working, the patient will not be able to do a proper OK sign, because the distal interphalangeal joints will go in for extension and the patient will show a OK sign like this. So this is called as OK sign. So for interosseous nerve, the sign is OK sign. So how you will identify interosseous nerve lesion? You ask the patient to make a perfect OK sign. You will not be able to do, because of the lack of flexion of the interphalangeal joint and the distal interphalangeal joint of the index finger. The OK will become like this. This is not a OK, this is OK. So this sign is called as OK sign. So please remember, ape-thumb deformity, hand of benediction, pointing index, thenar muscle wasting, all are signs of median nerve lesion. Yes, accepted. OK sign is a specific sign for anterior interosseous nerve injury. It's a specific sign for anterior interosseous nerve injury. Since we have seen about this fracture, 2 or 3 points about this fracture. So supracondylar humerus fracture, when it happens, it causes occlusion of the brachial artery. When the brachial artery gets occluded, it results in a problem called as compartment syndrome. It results in compartment syndrome of the forearm. It results in compartment syndrome of the forearm, and whenever there is a compartment syndrome, the muscles goes in for ischemia. Muscles goes in for ischemia. When the muscles goes in for ischemia, it is called as Volkmann ischemia. It is called as Volkmann ischemia. So Volkmann ischemia, okay, is an important finding in complications or important take home message for the complications of supracondylar humerus fracture. So whenever there is a supracondylar humerus fracture, especially type 3, okay, so there are three types of supracondylar humerus fracture. Okay, so there is a classification system for that is called as Gartland classification. Gartland classification is, you divide the supracondylar fracture into type 1, type 2 and type 3. Type 3 is a completely displaced fracture. Okay, is a completely displaced fracture. It is a completely displaced fracture. Whenever there is a completely displaced fracture, all these complications can arise. Nerve injuries, vessel injuries can arise that can cause lot of sequelae. So one such sequelae is Volkmann ischemia and one such sequelae is anterior interosseous nerve injury. Okay, all these are problems of supracondylar humerus fracture. And when you take supracondylar humerus fracture, most commonly supracondylar humerus fracture goes in for malunion. It goes in for malunion. Okay, whenever a supracondylar humerus fracture goes in for malunion, it results in a classical deformity. Okay, so the patient will have a deformity like this. Okay, the patient will have a deformity like this. Can anybody tell me what is this deformity called as? When a supracondylar humerus fracture, the patient will have a deformity like this. Okay, the patient will have a deformity. Yes, it is called as gunstock deformity. Very good, Hari. Very good, Vinita. It is called as an gunstock deformity, which is also called as a cubitus, varus deformity, which is also called as a cubitus varus deformity. Very good. So whenever there is a supracondylar humerus fracture that goes in for malunion, that results in a deformity called as gunstock deformity, also called as cubitus varus deformity. Please remember, whenever there is a deformity, the carrying angle is reversed. Okay, so there is an angle in the elbow which is called as a carrying angle, where the elbow is outside. So it is the forearm is deviated outside. Okay, it is deviated laterally. This is called as cubitus valgus. When there is a cubitus varus, there is a loss of or reversal of the carrying angle. So the carrying angle gets reversed. It results in a cosmetic deformity which can be corrected by an osteotomy called as modified modified French osteotomy. So there is a surgery called as modified French osteotomy. So you do modified French osteotomy to correct this deformity, So since we have discussed about supracondylar fracture, these are all the important points regarding supracondylar humerus fracture. So supracondylar humerus fracture, anterior interosseous nerve injury is very common. Okay, after that median nerve injury. Okay, so more common is anterior interosseous nerve injury. And always please remember, when there is a gunstock deformity, this can also result in another nerve palsy. Which is called as tardy ulnar nerve palsy. Tardy ulnar nerve palsy is commonly seen in lateral condyle of humerus fracture, but it can also be seen in supracondylar humerus fracture. So please be clear in this. Tardy means slow. It is not an acute presentation. When the elbow goes slowly for deformity, okay, so the ulnar nerve gets stretched. That is why it is called as slow. It is called as tardy ulnar nerve palsy. So please remember, anterior interosseous nerve injury more common, followed by median nerve injury. After that, slow presentation or late presentation, tardy ulnar nerve palsy can be seen. Okay, this fracture, when it unites, many times it malunites, resulting in gunstock deformity or an cubitus varus deformity, treated by modified French osteotomy. If the brachial artery gets injured, if there is a vascular injury, if it is not addressed properly, it can result in Holtzmann ischemia. It can result in Holtzmann. All these are important take-home messages for supracondylar humerus fracture. So please be clear in this. Okay, so we are done with the median nerve. Okay, and we are slowly moving into the ulnar nerve. So before going into the ulnar nerve, guys, I'll just highlight you in one area. Okay, so that is the carpal tunnel. We'll just see how the carpal tunnel is formed. Okay, so I'll take this part, this area for carpal tunnel. Okay, I'll just draw the carpal tunnel in this, and we'll discuss about carpal tunnel. Since we have discussed a lot about carpal tunnel syndrome, we'll just finish the anatomy of the carpal tunnel so that it will be easy for you to correlate the things here. See, when you take the carpal bones, okay, the carpal bones are arranged in two rows. I hope you know this is the lateral side and this is the medial side. So on the lateral side, you have the proximal row of carpal bones, namely the scaphoid, namely the lunate, and next comes the tricutral. Okay, sitting over the tricutral is the pisiform bone. This is the proximal row of carpal bones. The distal row of carpal bones are the trapezium, the trapezoid, the largest carpal bone, that is the capitate, and the hamate with its hook on it. Now this carpal bones are bridged by a retinaculum called as the flexor retinaculum, and this flexor retinaculum, it is attached laterally to the scaphoid. Okay, so what is this? This is flexor retinaculum. And this flexor retinaculum is attached laterally. It is attached laterally to the trapezium bone. It is attached laterally to the trapezium bone and to the scaphoid bone, and medially, okay, and it is medially attached to the pisiform bone and the hamate bone, okay. So this is how it's attached. Okay, so to put a simple schematic diagram, if you see the carpal bones, so let us consider these are the carpal bones. I am just drawing a single row of carpal bone. Okay, so you have the tricutral and the pisiform. Okay, so this is scaphoid, and let us consider this is pisiform. That the ligaments are attached in such a way, it is attached laterally to the scaphoid and medially to the pisiform bone. Okay, this is the attachment of the flexor retinaculum. See what happens to the flexor retinaculum on the lateral side? It gives a deep slip. Okay, and on the medial side it gives a superficial slip. On the medial side, this is the superficial slip, and this superficial slip is also called as the volar carpal ligament. It is also called as the volar carpal ligament. This is called the volar carpal ligament, and this side it gives a deep slip. Okay, now there is a tunnel between the flexor retinaculum and the carpal bones, and this is called as carpal tunnel. What are the structure that passes through it? The structures which passes through it are the following tendons. Okay, so you got the flexor digitorum profundus tendon and the flexor digitorum superficialis tendon, which are running through this, and they are surrounded by a bursa, and this bursa is called as the ulnar bursa. This bursa is called as an ulnar bursa, and on the lateral side you get a tendon. This tendon is called as the flexor pollicis longus tendon, and this flexor pollicis longus tendon is surrounded by a bursa called as radial bursa. Okay, so I'll just mark this so that you can able to understand this. So what are this tendon? These are called as the flexor digitorum superficialis tendon, and this tendons are called as flexor digitorum profundus tendon. And what is this bursa? This bursa is called as an ulnar bursa. This is called as ulnar bursa. Okay, this is called as ulnar bursa. And what is this tendon? This tendon is flexor pollicis longus tendon, and the bursa which is surrounding it is called as a radial bursa. This is called as radial bursa. So guys, please remember, the tunnel is very narrow. Within that narrow tunnel you got lot of tendons which are running, and these tendons are in turn surrounded by synovial sheaths which are called as bursas. So in any inflammatory conditions of the body, like it may be rheumatoid arthritis, it may be diabetes mellitus, or it may be an acromegaly, in all this, when this bursas inflame and when they enlarge, they compress a nerve which is running here. This nerve is the median nerve. Okay, so this nerve is the median nerve. So this nerve is the median nerve. Okay, so median nerve gets compressed, so that results in a syndrome called as carpal tunnel syndrome. Now on the lateral side there is a deep compartment where you get a tendon which is running here. This tendon is called as a flexor carpi radialis tendon. This tendon is called as flexor carpi radialis tendon. So these are the structures which are running through the carpal tunnel. I think I don't want to enumerate it separately. You can understand that flexor digitorum superficialis, flexor digitorum profundus, flexor pollicis longus tendon are the tendons which runs within the carpal tunnel along with flexor carpi radialis on the lateral side, and they are surrounded by bursas, ulnar bursa and radial bursa. In between them runs a median nerve. So please be clear in the structures which are running through the carpal tunnel. The structures running outside the carpal tunnel are, on the lateral side you got the palmar cutaneous branch of median nerve, and you got the palmar cutaneous branch of the ulnar nerve on the medial side. In between them you get a muscle which is called as the palmaris longus muscle. So you get a tendon here which is called as the palmaris longus tendon, and on the medial side beneath the volar carpal ligament you have a nerve, okay, which is running here, and you got an artery which is running here. Those are the ulnar nerves and the vessels. So what are these? Yes, what are these? These are the ulnar nerves and the vessels. These are the ulnar nerves and the vessels. These are the ulnar nerves and the vessels. Okay, so with this we have done with the carpal tunnel also. Formation of the carpal tunnel we have done. Structures passing through the carpal tunnel we have done. Structures passing outside the carpal tunnel we have done. Yes, anybody? What is this? So this is called as the palmar. This is called as the palmar cutaneous branch of the median nerve on the lateral side, and this is palmar cutaneous branch of the ulnar nerve on the medial side. Okay, and in between them runs the palmaris longus tendon. So these are the muscles which are tendons and the nerves which are running outside the carpal tunnel. Okay, so I hope you are clear with the carpal tunnel. Carpal tunnel syndrome is a very frequently asked area. So whenever they give conditions like acromegaly or diabetes or hypothyroidism or rheumatoid arthritis, any inflammatory condition where you see there is an increase in swelling of the tendons, then there is a high probability for the nerve to get compressed here. Okay, so I hope you are clear with the median nerve. So we have done with enough of median nerve. We have done with the nerve injuries. We have seen the muscles which are supplied by the median nerve. Okay, so with this we'll move to the next topic, that is the ulnar nerve. Okay, so before ulnar nerve we'll just take a short break. Okay, and then we'll resume with the ulnar nerve. Okay.